Hi, I'm Dr. Adam Warzonik, a psychologist in the Multidisciplinary Pediatric Feeding Disorders Program at Children's Healthcare of Atlanta. Today I'm here to talk to you about pediatric feeding disorders in individuals with 3q29 deletion syndrome. 3q29 deletion syndrome is caused by a rare 1.6 megabase heterozygous deletion on chromosome 3. It has an incidence rate of about 1 in every 30,000 to 40,000 births. The syndrome is associated with a range of neurodevelopmental and psychiatric phenotypes, including mild to moderate intellectual disability, developmental delays, autism, anxiety disorders, and schizophrenia. Additionally, individuals with 3q29 are at a high risk for failure to thrive, for reduced birth weights, and for growth deficits. A recent study by Glassford and colleagues found that 64% of individuals with 3q29 deletion syndrome reported experiencing feeding problems during the first few years of their lives. The Glassford study noted, however, that the feeding problems reported were not defined by any set of specific criteria, and that more research was needed on the prevalence of specific feeding concerns within this population. After all, most children experience some difficulty with eating, from not eating their vegetables to eating too much junk food. So it's important to know, is that what these individuals were experiencing, or was it something different? Approximately 5% of all children experience chronic feeding concerns beyond normal developmental variation. Pediatric feeding disorders is the medical diagnosis defined as impaired oral intake that is not age appropriate, and it's associated with medical complications in early childhood development, nutritional deficits and related diseases, oral motor deficits, and general disruption to daily living to the children and to their families. These children often report significant growth deficits, and they're malnourished and they're underweight, and many restrict oral intake of food to such an extent that they require either supplementation through a nutritionally complete formula just to maintain their growth and avoid nutritional disease states, or, in more extreme cases, through the implementation of a feeding tube directly through their stomach and small intestine. So we wanted to know, what is the extent of the specific symptoms of pediatric feeding disorders within the population of individuals with 3q29 deletion syndrome? Additionally, children with pediatric feeding disorders also have developmental delays. And since developmental delays are also common among children with 3q29 deletion syndrome, we wanted to know if children with 3q29 and comorbid developmental delays were more likely to report feeding concerns than for children with 3q29 who did not have comorbid developmental delays. To answer this question, we in the Emory 3q29 project reviewed self-report data from 83 individuals with 3q29 deletion syndrome and 59 control participants. In addition to self-reported medical history, individuals also responded to an 11-item feeding questionnaire based on the most frequently reported behavioral, nutritional, and medical concerns related to pediatric feeding disorders. Our findings were pretty remarkable. For individuals with 3q29 compared to controls, there were significant differences on 10 out of 11 pediatric feeding disorder items. They were more likely to be dependent on either a feeding tube or a formula, more likely to refuse all food by mouth, 7 times more likely to be a picky eater, 4 times more likely to refuse all foods from 1 or more food groups, 15 times more likely to engage in problem behavior during meals to avoid eating food. They were more likely to have a history of failure to thrive or anemia, less likely to feed themselves. Just across the board, these individuals demonstrated increased presence of symptoms of pediatric feeding disorders. For those with 3q29 and developmental delays compared to those with 3q29 without developmental delays, there were significant findings, though not as all-encompassing as the overall 3q29 population. Comorbid developmental delays resulted in an increased likelihood of being described as a picky eater, increased food refusal behaviors, and a history of failure to thrive. It's clear that pediatric feeding disorders are a major concern within the 3q29 population. These individuals are already at an increased risk for neurodevelopmental concerns. Given that, the nutritional deficiencies, insufficient caloric intake, and poor growth, these things can all have a significant impact on cognitive development. Therefore, screening for pediatric feeding disorders should be standard practice for pediatricians serving these children. The good news is that pediatric feeding disorders are treatable. Current best practice follows an intensive multidisciplinary intervention in day hospital settings with a team of psychologists, dietitians, speech and language pathologists, and GI doctors, all working to expand oral food intake and reduce dependence on formula and enteral nutrition supplementation. Early intervention can help increase oral food consumption and can help prevent or reduce the negative impacts from poor nutrition on childhood growth and development, and therefore should also be a high priority for pediatricians working with these children. Thank you for your time and attention, and a big thank you to the Emory 3Q29 project.